Okay, we'll start off the afternoon session next with very similarly to how we ended the morning session. We're again going to ask our most experienced and senior physicians to give us their favorite way to diagnose SI joint pain. And I call this the lightning round, just because it's supposed to be relatively quick. 5 to 10 minutes, but just to talk about their favorite way to diagnose it. And so we'll start off with Dr. Pierre Demicourt, who is a physician out at Harvard, Boston Children's, and is going to talk about his favorite way to diagnose it. So, thanks, Pierre.
Thank you very much. It sort of depends. I don't think there is one perfect way to do it. But over the past year, I've been spending some time learning from some fellow osteopaths that I know that work with me, and going online and learning some things. But basically, what I came down to is I don't think I ever really truly understood how the SI moves in relation to the rest of the body, essentially. And so, it's osteopathy where I am, but there's many other terms for it in other parts of the world. So. Anyway, this is what I basically understand. Okay, so when I got into medical school, I actually had a choice of going to an osteopathic school or an MD school, and I thought about it both ways because I had some good friends. And over the years, long years, I hear people talk about upslips and torsions and all that, and I sort of understood, but not really having a good idea. So I started doing some online courses just so I could get a better fundamental idea. And I don't know if it'll help you, but it helped me feel like I understood what was happening both biomechanically and where the pain was actually coming from. So basically, we're going to look at sacral dysfunction and innominate dysfunction. So, and what's the difference between the two? Innominate dysfunction is a dysfunction, they're very similar, but the innominate dysfunction is a ilium dysfunction, usually related to something in the lower extremity, like a limb length discrepancy or something like that. And a sacral dysfunction is when it's twisted or turned, something is happening at the SI joint relative to the sacrum. So anyway, this is basically how I look at it. So we'll start with sacral dysfunction. And sacral dysfunction is when, flexion of the sacrum is a nutation, counter nutation is backwards, of course, but as you walk, it sort of tips forward like that. So if it gets caught and you have one end of it sort of not functioning well, then you have either a right axis or a left axis, okay? And they usually give two terms for it. The first term is where it's facing, and the second term is the axis. So you figure out the axis, and we'll talk about that in a moment. And then which way it's facing. So if the sacrum is facing left on a right axis, then it's left on right. And again, I'll come to more of that in just a few moments. And so the very first part of this in determining it is you do a seated bending test. Not the standing bending test is more for the innominate dysfunction. The seated bending test is for the sacral dysfunction. So you have your thumbs right on the PSIS, right up in here. So your thumbs will be buried right in there, and if I keep that thing still, and then you're going to have them bend forward and have them do it a couple of times so that you get a good feel for it. It's usually I many times can't pick up the PSIS until I have them flex, and then I can feel it, and then I have them come back and then flex again. And the side that catches and goes up is the dysfunctional side. So that would that's the side in choice, and therefore the axis is on the opposite side. So if that right PSIS goes up further than the left side, then the dysfunction's on the right side, and the axis is the left axis. So this is one of 4 maneuvers. Then you're going to place them in the prone position, and you're going to feel for those PSIS again. You're going to feel them go into the sacral sulcus, and this time you're doing 2 things. When your thumbs are up there, you're feeling for which side is higher than the other, and you're feeling for where the sacral sulcus is. The sacral sulcus is really the most important part. So if they're deep on the right and shallow on the left, you note that, and then you bring your thumbs down to the ILA, which is right there on that on the bottom side. And it took me a long time to figure that out. And on big people, I really have a hard time still, of course. But on most people, you can actually feel that ILA. You just slide your thumbs down so you get the points on that lateral part of the sacrum. And so if you have a deep sacral sulcus on the right, and it's a torsional deformity, say left on left, then the that left ILA will be high and the sacral sulcus will be low. Because if you think about it, if it's turning this way, this side goes down and deeper, and this side comes up, which is more shallow. And so that's your second maneuver, is to have them prone, feel for that sacral sulcus, and determine where the deep sacral sulcus is. The third maneuver is just to slide your thumbs down on that ILA. That's not quite yet. Sorry. Those got mixed up. I don't know. There's one of these slides got mixed up here. But anyway, so your first maneuver is to feel the PSIS, feel where the deep sacral sulcus is. Okay. Then you're going to slide your thumbs down, and you're going to feel where the ILA, the inferior lateral angle of the sacrum is, and you'll note that, and that kind of tells you which way it's actually facing. Now you don't really know yet whether it's an anterior or posterior tilt. So now you're going to do a spring test where you put the butt of your hand on the sacrum, and this takes a while to learn, and you kind of go up and down with a compression, and it should move a little bit. But if one side is stuck, like if the left side is stuck up and it won't move, then that's a sign of a posterior rotation, which is a more significant and more painful type of rotation. So you've done the seated bend test to see which side moved up to determine that that side is the problem. Number two, you're going to lay them down in the prone position, and you're going to feel which side is the deep sacral sulcus on. The third maneuver is you slide your fingers down to find the ILA, and usually if it's a torsion, the opposite side will be up. I'll talk in a moment about shears, which will be opposite of that. So now you've gone through those three maneuvers, and then you're going to do the spring test, where you put the butt of your hand on the sacrum and feel if it moves. And it should move a little bit, but if one side doesn't, that probably means that it is stuck backwards, and that is a posterior rotation. And then finally, you do the Sphinx test with your thumbs on those PSIS, and you're feeling that you say you have a deep sacral sulcus on one side and you have a shallow sacral sulcus on the other, and they come up in the Sphinx position. If it equalizes out and both sides go down just as deep, then that's an anterior nutation, which is less significant. But if it gets caught in that posterior position, then you know it's a posterior nutation. So that is basically the sacral aspect of it. Now, the innominate, there's a spring test. I meant to put that over there before that. But anyway, so those are the two tests that you actually test for whether it's a posterior or an anterior nutation. Now, for innominate dysfunction, it's really easy. You do a standing test, because in the seated test, you're actually taking the legs out of it and you're just seeing if the sacrum is actually caught. When you're doing the standing position, the whole lower extremity comes into play. So if one side goes up, then you know that's the dysfunctional side. And then all you do is you lay them down supine, and you feel for the heights of the ASIS, and if the left ASIS is up and turn them back over, and so what will happen is with a rotation, when you're prone, it will be higher this way, therefore the ASIS on the front will be lower. And so there you have on that left side, there you have a lower left ASIS, and in the back you have a higher, you have a higher right ASIS on the right side, and it's lower on the right side in the supine position. Therefore, you just have an ilial rotation, and that's an anterior ilial rotation. So posterior is just the opposite of that. And the value of this is that when you actually, and I'm sorry, there's one more thing. Is if you then find that both sides in this position are elevated, so if you get the position, situation where the ASIS and the PSIS are elevated or higher, then you have what's called the innominate shear. So with the innominates, you can either have a rotation or a shear. And sort of putting that all together, I think you'd have to look at the slides. That took me a long time to try to memorize these very simple diagrams. But you look for sacral rotation, and you look for shear and innominate shear and innominate rotation. The value of it that I learned was that if you understand the position of the sacrum and the ilium, and it corresponds with where the pain is, you can do some. I don't do any rapid stuff. I do muscle energy stuff. So if I have an anterior ilial rotation, I just simply put them on their back, and I get their legs straight up, and I have them activate their hamstring for 10 to 15 seconds and keep holding that there. And then I lay them on the side, and I don't do any jerking motion. I just kind of help rotate their pelvis in that same direction. And this at times can be very diagnostic. It doesn't work 100% of the time, but if you get somebody in your clinic and you can't figure out what they have, whether it's hip or coming from the facet joints, and you do a innominate rotation or whatever rotation it is that you're using, and they get better immediately, it's kind of interesting.
So will you actually feel the SI joint move when you do that? Will you hear or feel an audible pop? Or is it the patient feels better? That's your success.
I think the guys that are really good at it could do that. I can't say I feel it, but they feel better.
The patients do it right away.
Actually, in a couple of EDS patients that I've had, I did think I felt something, but it's subtle.
Yeah, that's fascinating. I'll have to try it. I don't think I have good enough hands to feel that. Also, I think, do those tests, are they very, my practice, I have a lot of larger patients, their BMIs are heavy, and I don't think that a lot of them fit. What's the cutoff? Like when? So
that's a good question. So what happens is I also do a pelvic neutral position. So I have them do a bridge and come back down, and I can usually get the ASIS. Getting the PSIS in a big patient is really almost impossible.
Yeah.
So I look at that, and I look at the length of their leg, and there's a good chance that their left leg is longer and the ASIS is down, that it's a posterior rotation. So you have to improvise a little bit like that.
Yeah. Okay. Thank you. Okay, next, Dr. Kurosawa, our vice president, is going to talk about his favorite way to diagnose SI joint pain. So, Dr. Kurosawa.
Okay, I'm glad to have an opportunity to present this topic today. This is my favorite topic to talk about this. This is a diagnostic algorithm of SIJ dysfunction in Japan. This morning, Professor Murakami mentioned about this. So now, I routinely hip examinations, including anterior impingement test and posterior impingement test, if the patient have a growing pain. So, and of course, I do the SIJ injection to diagnose, but I often added the hip injections to differentiate the hip pathology. So, in addition, I prefer to assess load bearing impairment and joint laxity. For load bearing, I evaluate gait and sitting posture. And for joint laxity, I check the ankle instability and ability to approximate the thumb to the forearm and hypermobility in multiple joints. When patients with joint laxity have done some accident that damage the SIJ, the posterior ligaments may become loose, resulting in a condition that is difficult to treat conservatively. So regarding the image findings, I check the hip dysplasia, including and the small size of pelvic parts. This patient, there are no arrow. So the left side image shows a small pelvic size So it may be called pelvic dysplasia, and we check the cam deformity on down view, and we check the lumbar sacral transitional vertebrae and the pubic symphysis instability. And in particular, I often focus on pay attention to the early unilateral OA changes in young patient at the painful SIJ side. After a series of examinations, an ultrasound-guided periarticular SIJ injections is performed in my outpatient settings. So I cannot indicate that, but this is a PSIS on the left side. The needle is inserted to the posterior ligamentous area. So if the patient, the needle insertion often can reproduce the patient pain. And so the needle insertion twice for the caudal section of the posterior ligamentous region, the needle insertion to the here, section 2, and the end, section 3. So if the patient have more than 70% pain relief of the pain relief scale, within 15 to 30 minutes after the injection, we diagnosed as having the sacroiliac joint pain. The pelvic belt test is also useful for SIJ diagnosis. Comparing its effect with a lumbar belt helps differentiate SIJ disorder from lumbar disorders. For difficult case not solved in the outpatient clinic, I admit patient for comprehensive investigations, including diagnostic intraarticular injections, and lead to the final diagnosis. This is intraarticular SIJ injections. So, and I also check the bone spectral CT scan. Accumulation in the sacroiliac joint region does not always mean pain in test itself, but it shows excessive load to or abnormal condition of the SIJ. It is important to evaluate SIJ disorder with lumbar and hip pathologies. We learned with physical therapists and engineers. Colleague of mine, a physical therapist, often finds the functional disorder around the sacroiliac joint. It's very helpful. So if we need, we aid on the diagnostic injection in the lumbar region and the hip joint. Okay. So finally, I would like to explain how we diagnose cases that require sacroiliac joint fusion surgery. First, we look at the effectiveness of SIJ injections when patients have more than 70% pain relief at the PSIS, and we also check the improvement in the load-bearing capacity of the lower limb with increased tolerance of turning in bed and longer sitting duration after the injection. So identification of SIJ inability is very important as a load-bearing impairment of the sacroiliac joint. That is an important thing that I learned from Dr. Ben Stussen. Other finding is very short sitting tolerance, less than 15 minutes, and I checked the SIJ uptake on SPECT CT scans. I also check the SIJ and hip joint comorbidities. It frequently associated with CAM-type femoral acetabular impingement. So initial management should address to the hip pathology. Only after that, sacroiliac joint fusion will be performed. So it means that hip first, SIJ last. This is my method. Thank you very much.
You mentioned the belt as a therapeutic agent, not just a diagnostic test. What do you tell patients about if the belt helps them? What do you tell them on how long to wear it and when to wear it?
How long wear?
If they respond to the belt and they like the way it feels, how do you tell them to use it?
So, okay, thank you very much for good questions. For female patient, Tanaka's functional pelvic belt should be applied as long as they can put all day and all night for 3 months. So, and the other belt should be applied in the walking and sitting, and so in the stressful situation in the daily life.
That's good information because maybe I'll change it. I do mine very differently, and I'm anxious to see what other people do that prescribe belts for their patients. But maybe I should do it more. I just tell the patients to wear it when they're upright, when gravity's stressing the SI joint. They usually don't have to wear it when they're supine in bed, and then when they're sitting, only if it helps them. So I don't know. Everybody else have different experiences?
I love the belt, and I have some ladies that voluntarily use it during the night. Not that tight, but they use it and say if they start the morning with less pain because of the stability they gain during, even if they're in bed. So they are painful when they turn in bed, so they profit from it. So I think it's a diagnostic tool. It's a therapeutic tool. Something good.
So Uti, functional pelvic belt is have a different concept, not tight, but hold softly, so that a female patient can put on during the day and night.
But you have changed my practice, so that's good. Excellent. Okay,
Thank you very much.
Thank you very much. All right, our next speaker, Dr. Donner, back up to take us through your favorite way to diagnose the SI joint pain.
Thank you again. Really, what I'd like to do is just walk in the OR and someone has a little mark on them and says, operate here and be done with it. But you almost have that, but you still do your own workup, which is admirable because I guess you want the feedback if they're not doing well. And that's the way I am in a way too with doing my own injections, which is part of this. But like most of us, we see a patient, we see a chart on the wall, we pick it up, we look at it, see what we're up against. And like I mentioned before, I think the pain diagram is a great place to start. Of course, you can have all sorts of marks all over the place, and I'm not sure exactly what that means until I get in there and ask them, okay, where's your number one pain? Where's the seam to start, and then work my way down the list if it's secondary type of, pain or symptoms. And then, of course, looking at the history is really remarkable. Looking at this lady's had, pain since, the 60s and another accident. So we're talking about 20 years after the date. So this was very common back in the earlier days where people weren't even getting diagnosed or treated. They'd be having this pain for a long time. And then, of course, you have the more classic, types of patterns that make you think differently. But all that changes when you start your examination. You walk in your room like we've seen, how they're sitting, as a kind of a clue. And then my, go-to in a way when they, sit there, I'll do the tension signs. I'll do a few exams while they're sitting in the chair, while they're comfortable. But what I really like to know is how much of this might be coming from the lumbar spine, and simply having them stand, point to where their pain is, and take them through some simple maneuvers in terms of lateral flexion, extension, rotation, flexion. Not major, where I'm probably stressing the hips or the SI joint, and trying to see if I can reproduce their pain that they're describing in their buttock or down their leg. And if I do, I kind of focus in that direction. If I don't, then I get obviously more attention to the rest of the examination, which we all know, we've heard. I agree. Like with Woody, I start with a favor. Not so much it may give me the best idea on SI joint pain, but it's a good way to examine the hip first and take it through all those tests, the flexion, adduction, internal rotation, looking for impingement, and then the Faber, and just rotating it around. But from there, I can kind of move and start doing the thigh thrust, which I find is more reliable. And I can do that in different ways, just like when we do the hip maneuvers. You can adduct it a little bit more. make it straight on. I test it in different angles because some of these stresses may affect one person, one part of their joint more than another. So I just don't want to say, well, it was negative because I tried it once. So I find that, and the other ones I add in for further validity. But it really comes down to, for me, is we've had this discussion many times, is an intra-articular injection. If I believe that that's the source, of course, while I'm there, I can certainly switch it up and do a nerve block, a facet injection, discography, a variety of these things, maybe not all at the same time typically, but, over time. And again, using small volumes is very important, as is brought up. If I'm doing a therapeutic injection, I'll just give them like 5 cc's, let it go everywhere. It leaks out the front, the back. All I'm trying to do is make them feel better with the anesthetic and steroid. But when it comes back to, hey, that felt great for a while, we may have to do something else, then we really do need to consider the low volume. And for these reasons, because we know it will leak out in the foramen. It can leak out in the front of the joint where you have your lumbosacral plexus. You're going to get fooled. A lot of these people could have an L5 radiculopathy, and you're going to think it's their SI joint because you got rid of that radiating leg pain because it leaks out the front. And again, as I mentioned, being able to do the nerve blocks and discograms, which I do, has been very helpful for me. It's kind of the extension of the physical examination. Thank you.
All right, Jeff, thanks. Dr. Reckling is going to come and give us his experience with the SI joint and the favorite way to diagnose it.
Good. I'm going to take a little bit of a different spin on this. Again, I'm the Chief Medical Officer at SI Bone. I'm an orthopedic surgeon, trained at Creighton, trained at the University of Minnesota, went to Nottingham, England, and did a spine fellowship, came back to Cheyenne, Wyoming, where I was the only orthopedic spine surgeon in a community of about 60,000 people. I was probably overtrained after my fellowship, and I practiced there for 20 years. And I'd like to thank some of my SI joint mentors along the way. Jim Ogilvie, who's a fairly well-known surgeon, maybe a generation ago now that I'm approaching the end of my career, but he dealt with complex revision lumbar spine, and he surgically treated the SI joint. He would do a modified Smith-Peterson approach, use an acetabular reamer to go through the ilium to the SI joint, take the reamings, pack it in there, and about half of his patients got better, but the residents learned about SI joint and how to diagnose it, and that we were early believers, and there weren't a lot of believers back then. And the next one on the list is one of those believers, and he was in my neck of the woods, just down the road from me about 40 miles, and we shared complex patients. We would help each other out with big giant revisions and big complicated surgeries, and he taught me the Donner approach to thinking about the SI joint and treating it. Along the way, I met Bengt Sturesen, who's here, Andrew Vleeming, who we all know, who's thought very long and very deeply about the SI joint and SI joint function, Joe Fortin, Heidi Prather, who's a PM&R physician in the United States, very much in tune with hip pathology and then the whole female pelvic floor, abdominal weakness kind of perspective on the SI joint. And of course, my friend and colleague, David Pauly, who really from the spine perspective has become an expert on the SI joint. So I'd like to thank those individuals. And I'd like to talk about the diagnosis in the context of a functional model, right? So Vleeming gave us Foreman force with Bengt's, assistance. Hodges in Australia has really tied in the concept of motor control. Hip pathology, spine pathology, SI joint pathology, abnormal muscle firing. Muscles fire in the wrong sequence, they don't fire in the correct duration, they might not fire at all. And as our PT colleague here was showing us, there are rehabilitation programs to retrain the muscle firing. And then this last piece, I don't think gets enough consideration, the position of the pelvis in space. Is the pelvis retroverted because of spine pathology? Is it anteverted post-pregnancy? Is there some sort of torsional element to it? And Lazanek in Paris and J.C. Louek, who's a spine surgery in Bordeaux, have talked about rotation of the pelvis in the axial plane, particularly after hip replacement, with increased femoral offset. The body compensates by retroverting the hemipelvis. The patient walks out of alignment. So it's really considering the pelvis in all three planes. Change the plane, you change the load on the SI joint. And the goal, as we've discussed, is effective load transfer across the SI joint. So yesterday we talked about that we're not operating for pain. It was posited that we should be operating for structure. And I think I might push back on that and say that we should be evaluating and treating these patients for function. We want to return their function. This functional model has some ability to accommodate. You could make your muscles stronger. You could make your muscles fire in a different sequence or fire longer. So I'm thinking more about this in the context of function. So SI joint diagnosis, that's what I'm supposed to be talking about. I think it's pretty good. I think we agree. I think there's consensus that you perform the history and physical exam, you do the maneuvers, you do the diagnostic injection. Peterson in the British Medical Journal actually did a study and showed that there's a pretty good clinical diagnostic rule for the SI joint. I think our challenges are the first two bullets. Rule out the hip and rule out the spine. I know for a fact that my spine colleagues wouldn't be very proficient at diagnosing posterior hip pathology, posterior cam lesion, ischiofemoral impingement, increased femoral aneurysm. Say those to some of my neurosurgical colleagues and, right, glaze over. And likewise, our hip colleagues probably aren't thinking about PILL mismatch, right? Half my spine colleagues don't think about PILL mismatch, so why would the hip colleagues be thinking about that? And then, as we discussed earlier, I think the spine surgeons and the hip surgeons are missing this whole pelvic floor dysfunction, postpartum musculoskeletal changes that affect the SI joint, and we're not even asking the right questions on the history and physical examination. We're not asking about sexual function. We're not asking about bowel and bladder function. We should be doing that. So part of the challenge, has been mentioned earlier, we have multiple specialties seeing and evaluating these patients, and there's not a common language. There's not a common structural model, lack of a shared understanding. And there's, in my opinion, a lack of a consistency and proficiency in the physical examination across specialists. This is a diagram that I really like, and I like to think about this as differential diagnosis of posterior pelvic pain and thinking about it topographically. And I think there's 5 areas that you can think about. The lumbosacral junction, the iliac crest, right? Superior cluneal nerve comes over the crest, right? The gluteus attaches to the crest. Those structures can be painful. The gluteus itself, right? The fleshy part of the buttock, deep gluteal syndrome. I know that none of my spine colleagues could name 5 causes of deep gluteal syndrome, but the hip guys couldn't rattle them off. Posterior lateral hip, right, where the piriformis inserts, and then around the ischium. All those things can overlap with or present in a manner consistent with SI joint pain. So why the emphasis on the why instead of the how with SI joint diagnosis? Well, think about the topographic, right, considerations of the posterior pelvis. Approach it with a layered approach. Deepest layer is the bone, right? Then you get your ligament and muscle and nerve. Build from the inside out. With regards to the spine, think about spinal alignment, spinopelvic parameters, and the position of the pelvis in all 3 planes. Deformities in all 3 planes will affect the SI joint. Think about the hip, particularly the posterior hip, lower extremity. A couple of the presentations yesterday at the hip conference were about the influence of, the rotational parameters of the lower extremities and their influences on the hip and hip biomechanics. And I'd really like to emphasize that last one, the pelvic floor and abdominal muscles. So the importance of the why, it will help us guide rehabilitation. Maybe we can be more thoughtful about what might be helpful to our patients and maybe a better conversation with our physiotherapists. Directing therapeutic injections. Maybe the patient needs a Botox injection into their piriformis. Maybe they need an endoscopic release of the sciatic nerve in the deep buttock. Maybe they have a gluteus minimus tear. So it can also direct the surgical decision making. If the hip is causing increased SI joint loading, posterior can, IFI, treat the hip. If there's a problem with the spine, right, they're out of sagittal balance, even though they have SI joint pain, you fix the SI joint, they're still out of sagittal balance. That whole muscular pull on the posterior pelvis is just going to continue the SI joint pain. They need an osteotomy and a realignment. And if it's SI joint pathology, right, they have dysfunctional abs and a dysfunctional pelvic floor, they failed physiotherapy, treat the SI joint. So I'm more of a why guy than a how guy. So with that, thank you.
I mean, courtesy of Dave Pauly, I think for me, I've paid a lot more attention to sagittal balance and its influence on the SI joint. So how do you assess in the clinic sagittal balance? And is there ever a role in some patients to treat the SI joint as maybe a cause of pain when they're leaning over to offset it? And I guess, how do you balance that evaluation and management?
Yeah, I would say that in this particular case, the imaging is helpful, right? So you can get standing films and you can really try and understand relationship of the pelvic incidence to the lumbar lordosis. And I think assessment on a sit-stand, right, lateral of the pelvis is also extremely helpful.
Sure. Is there a clinical, when they're in there in the room, you probably can, but those of us that don't do it a lot, can you tell right away that somebody has that problem?
Well, you can tell they're out of balance because their ear isn't over their pelvis, isn't over their ankle. Okay. But maybe they've got hip flexion contractions. Sure. Maybe they've got a knee problem. Yeah. Maybe they've got something else in the lower extremities that's contributing.
Yeah. Fantastic. Thank you.
Sorry. You're welcome. Thanks.